Go ahead and get started. I thank all of you guys for attending today. Some of you might have been able to attend a few months ago where we talked through hypothermia, and we weren't able to get to some of the case studies that I had included in those slides. So we wanted to kind of regroup today, and we'll go through some of the case studies as well as kind of hit the high points and review the main topics, the main conversation points related to hypothermia. If I didn't have the chance to meet you before, my name is Jenny McGowan. I'm from the University of Louisville in Kentucky in the States. Kentucky is known for horses, bourbon, and Kentucky Fried Chicken is usually what people know of us for. So we're going to talk through, and as we were saying, I just got back from Antarctica, and it is currently negative 12 degrees in Louisville, Kentucky today, so a very timely topic for all of us. We're going to start with reviewing the stages of hypothermia, just to keep in mind kind of what we're talking about, the findings that we'll find at each of these clinical stages. There's some overlap between them, and the temperatures aren't, it doesn't, if they're, there can be a little bit of overlap between them, but just kind of as a general rule. So when we talk about someone that's hypothermic, we're talking about a patient whose core body temperature, usually measured by a rectal or temperature sensing Foley or an esophageal probe, is going to be less than 35 degrees Celsius. In the first stage of mild hypothermia, usually we say that's between 32 and 35 degrees. And these are patients that are still alert, their mental status is intact, and they're shivering profusely. They're still able to warm themselves, but we need to assist them by removing them from the cold environment. Perhaps they were outside and their clothing got wet, or they've just been sitting immobile outside. These people usually, if you provide them with food, warm blankets, and get them out of a cold environment, they're going to do just fine and rewarm on their own. More concerning to us when discussing patients that present to an emergency department are going to be the patients that are moderate or severe hypothermia. This is as their core temperature continues to decline. So our moderate patients, 28 to 32, we start to see a decrease in their mental status, and we start to see them lose their ability to compensate. So they're no longer shivering. They're running out of their caloric reserves that help keep them warm. All of their vital signs will continue to decrease as their core temperature decreases. And without interventions and us helping them rewarm, they will progress to severe hypothermia, which is what most of the cases in this lecture describe. With severe hypothermia, usually then the core temperature is going to be less than 28 degrees. And at this stage, these patients are generally unconscious. They're no longer shivering. They're not able to generate any body heat on their own. And without further interventions, that core temperature is going to continue to drop until they ultimately suffer a cardiac arrest. So I have 4 cases here. We'll see if we can get through all of them. Our first case is Granny, as I refer to her, grandma. So this was a 93-year-old female that I had at our community hospital who came in with a chief complaint of being found down at home. EMS didn't have a lot of history for us. They said, well, her neighbors had called and said that they saw her about a week ago, so they had no idea how long she had been down on the floor. When she arrived, she was altered. She wasn't speaking to us, and she wasn't following any commands at that time. They were unable to get any hold of any family. They couldn't find a cell phone. They had no contacts for anyone. But we did have an ID, but she had never been to our hospital system before, so we had no idea any of her past medical history. So when we look at a patient like this, it's a very broad differential. And I want you guys to be thinking, all right, knowing just those things, what is on our differential? What kind of things, might be causing her to have this altered mental status? Because it's a quite broad differential at this time. And also, what other questions might you want to know from EMS? So our differential is quite broad again here. We're wondering, has this little old lady had a stroke? Has she suffered an intracranial hemorrhage? Is she in sepsis? Or what kind of organ failure are we looking at? If she's been on the ground for several days, is she in rhabdomyolysis? Has she suffered a trauma? Does she have a hip fracture? Has she had a heart attack? Has somebody been neglecting her? Is family aware that she was in this state? What other things could have went wrong? Does she have dementia? Did she take too much of a medication? Did she take not enough of one? So all of these thoughts are going through our head as we're doing our initial assessment of this little sweet little old lady that couldn't tell us anything. So we get our initial set of vitals on her, and our manual blood pressure, because the automatic one wouldn't read, was very low at 65/30. She was bradycardic with a heart rate of 50 and had decreased respirations of about 10. On room air, she was sitting in the upper 80s. But more concerning is we placed a temperature sensing Foley when we couldn't get a rectal temperature on her after we couldn't get an oral temperature on her, and found it to be very low with a core temperature of 25.5 Celsius. And again, if you remember, that is a profound hypothermia core temperature. So we looked at all of this and said, oh boy, this is going to be a bad day for us. So our next step with this patient, I was telling our staff, let's be very, very careful with her. We don't want to jostle her around too much. We don't want to move her too much. And let's keep her in one position in this bed, keep her calm, and try not to bother her. We wanted to make sure that we had continuous measuring her vital signs and temperature. So with the temperature sensing Foley, we could monitor that continuously to see changes and see how our interventions were working. We had frequent blood pressure checks on her to monitor this. We still didn't know exactly what caused Granny to become hypothermic and be found on the ground. We didn't know if this was a metabolic process that led to a fall, that led to her being unable to get up, versus if it was a primary hypothermia, if it was a medication effect. We still didn't know at this point. So we started a very broad workup, getting basic screening labs, as well as things for a sepsis workup, our blood cultures, our lactic acid, getting a creatinine kinase since she'd been down for so long, thyroid studies, urinalysis, kind of anything we could think of, toxicology screens that would account for what was happening here. And then these hypothermic patients are very prone to dysrhythmias, which we'll talk about. And so I was quite clear that this is a patient that needed to stay where she was. I didn't want her going to the CT scanner because realistically, even if she had a stroke or a head bleed, this wouldn't necessarily, to getting her to the CT scanner a few minutes earlier wouldn't necessarily change our management as it had already been such a long time, but she was at such a high risk for an arrhythmia that we could have a much worse situation if we jostled her and she went into a dysrhythmia. I said, let's not move her around. The CT head can wait. There's a good chance her altered mental status could be secondary to her hypothermia and not something that we need a CT scan of. So it's sometimes makes some people uncomfortable, but we say, you know what, if she has an intracranial hemorrhage or a CVA, it's okay. We can wait to find that out a little bit. So with this patient, we wanted to start our rewarming measures. And in this case, we chose active external measures. So what this means for her is we started with heated blankets. We started infusing warmed IV fluids. We were able to get some humidified oxygen for her. And we knew that if she did lose her pulses, if her blood pressure dropped further, if she went into a dysrhythmia, then if she went into cardiac arrest, we were going to have to consider our active internal measures of rewarming, which are our more aggressive measures that include things like placing chest tubes, doing thoracic lavage, in some instances peritoneal lavage, or in extreme cases, things like ECMO to try to rewarm these people, or dialysis. Now, we were worried about her as we started to warm her because there's always the concern for what we call after drop, which we'll talk about more. And that's when we want to make sure that we're warming her trunk before we warm her extremities. And my nurses were asking me, what about pressors? Should we start pressors on this patient? Her blood pressure's, 65 systolic. And, explain to them that the pressors really aren't effective at such a low core body temperature. But, let's give it a bit. Let's try to resuscitate her first. We can try a pressor. It's probably not going to do much at this time. I believe in this instance, we did start a low-dose pressor, but it was pretty ineffective. The biggest thing with these patients is to say, let's just be patient with them. Let's give this time and see if we can rewarm them. So we started our warming measures on her. We added our heated blankets, our warmed IV fluids. We're trying to slowly, surely get her temperature up. And another question that came up is intubation. Is this a patient that we should intubate? And there's kind of two schools of thought on this. There's going to be some people that say, yes, the patient is not protecting her airway. She has altered mental status. If she were to vomit, she would aspirate and we would be in a much worse situation. We should go ahead and prophylactically intubate this patient. And that's not wrong if you make that choice. My perception was I was looking at her and saying, I'm just concerned if I intubate her, It's going to jostle her around. There's some position changes. I'm going to be putting an endotracheal tube down her esophagus in very close proximity to the heart. I could be stimulating her cough or her gag reflex. If I do those things, she's at high risk to go into a dysrhythmia. And honestly, her mental status might be okay once we get her temperature up. So we decided not to intubate, but you will certainly find mixed opinions on if these patients, if we should take their airway and intubate them due to their poor mental status. So an hour later, we've been warming her, and now we get a repeat set of vitals, and our blood pressure is now dropping, and our blood pressure is 50/20 from a 65/30. We're becoming more bradycardic with a heart rate of 45. Our oxygen saturations now on heated humidified oxygen have improved a bit, but we still have low respirations, and our temperature is actually dropping, which with our warming measures, we would like to think our patients are going to improve, not worsen. So it's a moment to kind of reflect and say, well, what's happening? Why is grandma getting worse when we're doing all the things that, we're supposed to do? I had these lectures on hypothermia. I'm doing the things. How is she worsening now? And this is when we go back and talk as a reminder about after drop. So as a patient becomes hypothermic, they get vasoconstriction of their extremities. That shunts all the blood to the core to try to rewarm and keep warm the vital organs at kind of the expense at the periphery. As we start to warm a patient, that vasoconstriction is going to relax, and they're going to vasodilate on their extremities as our perception of temperature is closely linked to the skin temperature. So our extremities now, as they start to feel warm air, warm blankets, or even just room temperature is going to be warmer than what they were, they're going to vasodilate as it perceives this warmth. And with that, all of that cold blood in the extremities is then going to flow back into the core that previously was kind of shut off from the core. There wasn't a lot of blood exchange there. With that, you're going to have a mixing of the very cold extremity blood and the slightly warmer core blood. And when that happens, this is what we call after drop. The core body temperature is going to drop lower before it starts to come back up. With that, a lot of the times you'll see a drop in the blood pressure as well as the heart rate. So these patients will clinically get worse before they get better. The mental status might also decrease, and it's a worrisome stage because it makes a lot of our staff uncomfortable that this patient is not improving despite our warming measures. That's kind of the first step. So as we warm these patients, we typically will avoid warming their extremities and we'll focus on the trunk, trying to minimize this phenomenon best we can. With that, all of the warm blankets are applied onto the core and try to keep the extremities exposed. There's only so much we can do to limit this. Our goal is to just try to slow the process to not have such a pronounced drop in blood pressure, heart rate, and temperature, and try to do it more gradually. So at this time, we said, okay, we need to continue warming her. So we kept doing what we were doing, our active external warming measures. And 3 hours later, it looks like we're making some progress now. So our blood pressure is improving, our heart rate is improving, and our temperature has came up 1.5 degrees from where we started, 2.5 from our lowest point. And at this stage now, we're feeling a little more optimistic because our grandma is now moaning intermittently. And we said, we're very happy with this. This is good, slow progress, but we're happy. Let's keep doing what we're doing. We're seeing improvement. So our lab started coming back at this point. We found that she did have a high leukocytosis, as well as a significantly elevated lactic acid. We were giving a lot of fluid repletion at this time, and we'd also given her broad spectrum antibiotics. We did have an acute renal injury with a creatinine of 2.5, but her electrolytes were actually in pretty good shape. Her urinalysis looked exceedingly infected. And then we did note on her EKG that she had Osborne waves, which if we recall from our previous lecture, take a minute to reflect, Osborne waves are also known as J waves, and that refers to this J point elevation on the EKG. You see this upward deflection at the junction of the QRS and ST segment. You see it the most in the precordial leads, and these are a benign finding. They resolve with warming. They're not only seen in hypothermia, but that is the most common time that we see these Osborne waves. So in a patient like this, it's kind of a cool finding to look at their EKG and say, oh, look, they have Osborne waves. Yep, They really are cold. There's nothing to do. It's benign. You just rewarm them. Always fun to find them, though. So the patient was admitted to the hospital, started on antibiotics, and our caseworkers had their work cut out for them. And social work eventually was able to find some family, and they said that, oh yeah, Granny, she lives independently. You know, we check on her sometimes, but they were really not involved in her daily life at all. It was very unfortunate. And it was ultimately determined that she had been unable to afford her heating bill, and her heat had been turned off in the winter time. I believe this was around the end of November when I had this case a few years ago. And then at that time, we presumed that she became confused, had a urinary infection, had become septic, and at some point had ended up on the floor and gradually became hypothermic. And in this case, she was very lucky that her neighbors had noticed and had called for emergency medical services, and the paramedics arrived truly just in time for this sweet little lady. And over the next 48 hours, she was rewarmed. She received supportive fluids, oxygen, antibiotics for her infection. Her vitals continued to improve. When I had first talked to the ICU, they actually told me this was futile care and we should stop what we were doing. And I was I had a very strongly worded conversation with them that we were not stopping, that this was the right treatment. And her mental status improved. She proved all of those people wrong that doubted her. On the second day in the hospital, she was awake. She was conversant. She remembered nothing of the surrounding events. It seems she had a very mild degree of dementia, which sounded like that was probably her baseline. She was in the hospital for 6 days, received full treatment for infection. Physical therapy worked with her due to her debility, and social work worked to try to coordinate what would happen to her at discharge. The family never showed up to the hospital, although they lived in town. They never came to check on her and said that, you know, they were kind of uninvolved in her care, unfortunately. And ultimately, we have a service called Adult Protective Services that was notified for elder abuse and neglect. And I don't think anything really happened to the family, but a case was filed. But she was ultimately discharged to a rehab long-term facility. She was ambulatory. She was at her mental status baseline, had no long-lasting deficits from this episode. So she was very lucky that she had a neighbor that was looking out for her. Any questions about case one before we move on to our next one?
If I have 2 questions,
Sure.
As for vasopressors,
Mm-hmm.
We have a low affinity with vasopressors. In which stage of hypothermia?
So that's a great question. And I believe later I have a slide with some specifics on some of the medications. But as a general rule, if the core body temperature is less than 30, medications are just really not effective. They're designed to function at an optimal temperature and pH in our bodies. So when the core temperature is that low, they just don't really work. It's not necessarily harmful in most cases to try, but a lot of the times you won't get much effect, and would be very careful with the medication that there's a concern for potential toxicity, because the body does not clear and metabolize the medications at those lower core body temperatures.
Thank you. And last question I ask in the end of your lecture, okay?
Okay.
I have a question about this case.
Please.
Yes.
I'm interested, why did you choose not to move the patient at the beginning when she was taken to the hospital, that you even didn't take her to CT scan?
That is a great question.
Why it's important not to move them or change their position?
Mm-hmm. That is a great question that I have some teaching point slides on our next case. So that's a great segue into that one. I couldn't put all the teaching points in the first case. So with that, let's chat about moving patients that are hypothermic. So our case number 2, this gentleman is a 26-year-old male. Again, the complaints that our paramedics were called for was he was unresponsive. This is a December day about a year and a half or 2 years ago now, and he was found slumped over in a wheelchair outside of a homeless camp. The only people nearby were some other homeless individuals that knew him a little bit and said, yeah, he likes to use IV opiates sometimes. He has a history of substance abuse. The only thing that our paramedics could elicit from a medical history standpoint is he had clearly had 2 previous bilateral lower extremity amputations, but otherwise we didn't know anything about him, and he arrived at this time as a doe. So again, we have a pretty broad differential in this patient, but the history was very concerning for an opiate overdose, which is what the paramedics were thinking of. They found him to have decreased respirations of only 6 a minute. He had a pulse of about 60. He was bundled up in a big heavy jacket on a cold day. They said they couldn't get a blood pressure. They thought their cuff just wasn't reading over the jacket. He was unresponsive. His pupils, I believe, were small, but not pinpoint. His glucose was close to normal. And so our paramedics, rightfully so, were concerned for an opiate overdose. There were some needles and syringes nearby. They gave him several doses of naloxone without any response in his mental status. So at that point, they said, okay, well, let's go ahead. We'll transport him to the hospital for further workup. So they had him hooked up to a cardiac monitor in his wheelchair, and they picked him up, and they went from a vertical position to a horizontal position, and they flopped him onto the stretcher, and that was what happened to their cardiac monitor. And they said, uh-oh, he just went into VFib on us. And they confirmed patient was pulseless and now apneic. They said, well, crap. So they started CPR on this patient. They went ahead in the field and were able to intubate him. They started resuscitative measures. They defibrillated him 4 times prior to arrival, all of which were unsuccessful. They gave him a couple of rounds of ACLS medications. They gave him epinephrine 3 rounds, as well as amiodarone, and they started some fluids on him. He arrived here, and he was in ventricular fibrillation at the hospital still. And I think I said 23. I believe he was 26, but I was like, oh my gosh, 20-year-olds have healthy hearts. A 20-year-old should not just spontaneously go into ventricular fibrillation. That's wrong. That's a disease of older, more diseased hearts. And so despite the fact my nurses thought I was crazy, the first thing I was calling for during this resuscitation was, I need a core temperature. I need a core temperature. They were questioning my resuscitation skills at this point, saying, no, they need more defibrillation and medications. So our core temperature was 26.5, if you'll remember, which is similar to what our granny had in the first case, and about 1.5 degrees below the stage of what we call profound hypothermia. So very low on him. And we said, well, that will do it. So why did this happen? Why did he go into ventricular fibrillation? And getting back to the great question you asked there, hypothermic patients are very prone to dysrhythmias because their myocardium is very irritable. Any kind of jostling or movement will send them right into ventricular fibrillation or ventricular tachycardia if their core temperature is low, if they're in that profound hypothermic stage, or most anyone below 30 degrees. So even just a position change, moving this person even cautiously from the wheelchair to the stretcher, just irritates that myocardium to the point it can't compensate and it goes into ventricular fibrillation. So anything that we do to jostle the patient has to be done with as minimal movement as possible. I've seen patients that have survived transfers, the ambulance ride, that get to our resuscitation bay, and then just not moving them carefully enough to our main ER stretcher, we watch them lose their pulse in front of us. So it's very, you have to be very careful with these people, because it's so frustrating when you had someone that did have a pulse that you were just going to be rewarming, that now you have turned into a cardiac arrest by something that could sometimes be prevented with very careful handling. They're very fragile. So anytime you choose to do a procedure on these patients, if you're going to intubate them or place a central venous catheter, really think that through, if they need this procedure and how you can minimize the risk. So these are patients I would opt, if available, to use like a video laryngoscope to try to minimize the movement, place the tube very cautiously. If I were placing a central venous catheter, these are people I would usually try to place it in a femoral vein instead of a subclavian or internal jugular, just to try to minimize the irritation of the heart. Putting a guide wire into someone's heart when they're hypothermic is a way that can very often induce ventricular fibrillation. So we believe that's what happened with this individual. So the big difference between this patient compared to our previous grandma is that he has now already arrested. So at this stage, our active external warming measures aren't going to be sufficient. Those are more supportive measures for someone that we're trying to keep from arresting, but trying to rewarm. This is someone now that is going to, as he's in cardiac arrest, he is going to have no means of rewarming himself, and it is up to us to actively warm him by internal means. So there's different degrees of, there's different techniques we can use for different degrees of hypothermia. Our passive techniques are going to be what we would consider to be like supportive measures, when we just remove someone from a cold environment, get them out of wet clothing, and maybe give them a high calorie warm meal to eat to try to let them warm up on their own. That's for people that are doing fine, that are just a little cold, that have experienced a cold stress, that aren't even really hypothermic. For most of our mild and some of our moderate hypothermic patients, we can do these active external techniques for warmed blankets, warmed humidified oxygen, warm fluids, and then if you're available, any kind of forced warm air devices like a bear hugger or Arctic suns or different techniques that you can use for that, or just warm blankets. However, once these patients are in cardiac arrest, we need to consider more invasive measures. So some of these are fairly benign, like warmed IV fluids. And then other things, if they're available, there are some endovascular warming catheters that we can use. One of the hospitals I work at has this, but only one. They're still a pretty novel technique to use. We'll talk about those more in a bit. Hemodialysis is an option that can warm them several degrees an hour. And then you can do peritoneal or thoracic lavage by placing chest tubes or doing a small laparotomy incision to try to add warm fluids to try to directly warm the core. And then in some cases, if the facility is capable, an ECMO, an extracorporeal life support facility, may choose to place these patients on ECMO. And then many years ago, we did bladder and gastric lavage, and those are techniques that are no longer recommended. They don't really warm the core very effectively, and there's a high risk of complications with perforation or aspiration. So we really don't recommend doing those anymore. So the most invasive of these, as we mentioned there, is going to be your peritoneal lavage and your thoracic lavage. Thoracic lavage is something that is within the realm of an emergency medicine physician that to place chest tubes and do this lavage. It can be challenging to do these, especially if chest compressions are ongoing, which is the only instance of a cardiac arrest, would be the only entrance I'd really consider these. And a lot of the times you have to place both an anterior and a posterior chest tube to be able to flush through fluid through one and then drain it out of the other. And then a peritoneal lavage is not something that I routinely do. It's something that's exceedingly invasive. You're essentially doing a laparotomy on this patient. And then general surgery typically would have to be involved to do it. In an extreme measure of a young, good prognosis patient that had a rapid cooling that's in cardiac arrest, it would be something to consider if you don't have more advanced therapies, but it's very invasive at that time. And usually these methods are used if there's not ECMO capabilities or no better options. So with this individual, I was at an ECMO capable facility, but they said no thank you. So we continued to monitor his temperature. He was already intubated. We provided humidified oxygen, warmed fluids. We had a bear hugger, a forced heat blanket that we put externally. I did go ahead and place the chest tubes, two on each side for a total, or two on each side for a total of 4 in an anterior posterior configuration to start thoracic lavage, draining them through the posterior tubes. So like I said, it's a community hospital, but it's kind of a strange community hospital in that we have ECMO capabilities, but they weren't willing to do it. But we didn't even have a fluid warmer. So if you're ever somewhere that doesn't have a fluid warmer, fun fact, you can safely microwave IV fluids. So we just took the microwave from our staff break room and brought it into our resuscitation bay, and one of our techs assisted with just microwaving our fluids until they were tactile warm, not hot. You don't want to burn the individual, but we wanted them warmer than room temperature. So I also then was able to, they had upstairs in one of the units, they did have an endovascular warming, cooling probe, and I was able to place that, which was my first time placing one. It's basically just like a central line. And you can set the target temperature. So for him, I said, what's the maximum on this thing? And I cranked it up, and 37 was the maximum on this particular machine. So I turned it up to 37 and said, all right, let's see what we can do. And this is what that looks like. I apologize for the poor quality. And again, this is just something to be aware that exists, that, maybe in the next couple of decades will become more common to see, but this was my first time using one. And it's basically just an extra long central venous catheter that has balloons along the part that's actually inserted into the femoral vein. It always goes in the femoral vein due to its length and size, but these balloons have water that circulates through them from the machine that's set at the target temperature, and it circulates through some extra ports and goes in, circulates through those balloons to exchange heat directly with the blood that is flowing past it. And with this, you can get an extra few degrees an hour of warming measures with a lot less effort than the other means. So kind of cool. Like I said, this is the only hospital I've worked at that has one, but hopefully something that will become more common, because it was pretty easy to place and pretty low risk to the patient compared to some of the other more invasive methods that we do. So the patient's now intubated. We had warm water infusing through the anterior chest tubes. We were draining through the posterior. I'd placed this endovascular catheter. We had a temp sensing Foley in to monitor his temperature. We had a mechanical compression device that we had borrowed from our local emergency medical services that plugged into the wall with a charger, and had ongoing CPR with that device. And I had a nurse and a tech monitoring, but I was solo coverage in that emergency department. These resuscitations can take hours. So at that point, I said, well, we're not using medications or doing pulse checks because our core temperature is so low. So until he warms up a little bit, I guess I'm going to go see some patients. And I can tell you that felt very strange to walk away from a critically ill cardiac arrest to go see others. But patients didn't stop checking in just because he was cold and was in cardiac arrest. So that's the reminder that, these patients aren't dead until they're warm and dead. Their core temperature has to improve to a point that we can then deem, okay, they're warm and dead, and we no longer need to continue resuscitative measures on them. So I said this is going to be several hours probably until we're ready to run this code like we normally would for a few rounds and see what happens. So it took us 4 hours, and he actually warmed rather quickly, and we got our core temperature up to 32.5 degrees. 30 is kind of the lowest temperature that I would consider calling a cardiac arrest. I'd want to warm them up until at least 30, but he was warming up pretty well, so we let him keep going a little longer. At that time, we reinitiated our ACLS measures with pulse checks, rhythm checks, and then a few rounds of epinephrine. At this time, the patient was not in VFib any longer, but was in asystole, and a bedside cardiac ultrasound showed no cardiac activity at all. So we did call time of death at this time. In this case, obviously we would like to have a good outcome on all of our cases, but realistically that doesn't happen. But this was one I appreciated because 4 hours of warming someone is actually not a very long time. And I thought this was a nice way to see the novel application of this warming catheter. And a good reminder of kind of the basics of position changes and their importance of avoiding them, because I'm not blaming the medics. They had to get us the patient. They had to change the position. But it's unfortunate that, perhaps if this patient hadn't went into cardiac arrest, we might have had a better outcome. So, questions about this case?
Колеги, чи є у когось питання щодо цього кейсу?
No
Будь
question,
ласка.
thank you. Everything.
Okay. I'll move on to our, and this, just a reminder on him, our last slide, that this is a patient that ECMO could have been utilized on, as he was a relatively young individual that was in ventricular fibrillation. However, a lot of centers, ECMO is a very, very, very expensive, high resource thing to consider. And a lot of places are very hesitant about what patients they'll place on ECMO. And it has to be someone that the team feels has a high chance of survivability. Otherwise, on his, the only other things to mention is his potassium was 5.5 and repeated a few hours later and was 6. However, if his potassium had been greater than 12, that's also a marker that we could have discontinued our resuscitation efforts, even if he had not warmed. the rest of his labs were largely unremarkable. So this is someone that, again, if we had avoided the cardiac arrest, we might have had a better outcome.
So main parameter for decision of ECMO usage, it's level of potassium. Is it correct?
Not necessarily. That's one of the markers. If the potassium is high, they certainly would not initiate it. The biggest indicator for if our surgeons are willing to do ECMO or not is honestly kind of surgeon dependent. Some are much more aggressive. The ECMO program, at least at our facility, has a pretty close oversight of their metrics and their survivability. So they're quite, unfortunately, hesitant to place someone on ECMO that they perceive won't have a good outcome because that will harm their program metrics that are carefully watched. So they really like to choose patients very carefully. And in their mind, and they only have 2 ECMO circuits in our entire region that are both at this one hospital. So especially during COVID times, it was very challenging to get someone on ECMO because they really had to look and say, okay, the only person, we have 1 circuit available and 10 people that would be a candidate. So they sometimes have to make those hard choices of who is going to be the best outcome, best neurologic recovery, best chance of survival. So in that one, they said, unfortunately, it was someone with an unknown downtime with a history of substance use at a homeless camp. And their concern was, did this person have an opiate overdose and then became hypothermic? Is this not primary hypothermia? They said, we're not willing to take that chance. So I understand, but it's unfortunate because I wish that we could do the best treatment for every patient every time. And that's unfortunately just not feasible sometimes. However, talking a bit about ECMO, this was a case that we had. It was one of my colleagues, but they had called me when she came in to help kind of facilitate care and to think about ideas, knowing that I have an interest in hypothermic patients. And this case was just last Friday. I'd actually already finished most of the slides for this presentation and said, uh-oh, I need to do some revisions. And so this lady came in. She's a 30-year-old female. We had a very, very cold few days, and she was found in the woods near a homeless camp, unconscious and unresponsive by paramedics. They found her to be apneic and to have fixed and dilated pupils. She was asystole on their cardiac monitor, but some bystanders were like, oh, we saw her moving around. She was making some noises about an hour ago. And there was no lividity or rigor mortis present on the initial exam. She was very cold to the touch. It was quickly recognized that this patient was probably hypothermic, and it was around 0 degrees outside on this day. And this was early afternoon, so presumed she had been probably out in the elements since the overnight. So per our hospital protocol, the paramedics actually called our emergency department to talk to the on-call physician for medical control and said, this person is dead. We'd like permission to not start resuscitative efforts and just declare them dead. And our resident that took the call actually did a great job of coming to find us and talk to us that said, I don't think we can do that on someone that an hour ago was alive that's hypothermic. And we said, you're correct. So we said, nope, you need to start CPR on this patient and you need to transport them to a higher level facility. So the medics picked the patient up, going back to that myocardial irritability again, and they moved her to the stretcher. And once they got her in the ambulance, they said, oh, she's now in VFib. So it's hard to say if she was ever truly in asystole originally, or if she was just in such a bradycardic rhythm that they didn't perceive a pulse and just said, oh, it's just a few pulseless electrical activity beats. She's really in asystole. But now she was in VFib. And they said, uh-oh. So they intubated her. They gave her 3 rounds of epinephrine. And then on the drive to the hospital, they defibrillated her 5 times. And that's kind of a time that I like to reflect and say, okay, when she came into the hospital, that's one of the questions I asked my residents. Would you have done anything differently on this? And of note, they couldn't get a temperature on her because she was so cold and they only had an oral thermometer. So some leeway with them. They didn't know what her core temperature was. But that's a reminder of what do we do for these patients that are so hypothermic? How much do we intervene versus how much do we warm? So again, these patients that go into ventricular fibrillation, it's very common if their core temperature is less than 30 degrees. And it's reasonable to do 1 to 3 shocks if these patients come in cardiac arrest. Some literature says just try to defibrillate 1 time. Others say up to 3. There are some resources that say do 1 defibrillation. If it doesn't work, warm them about 5 degrees, then try again. My general rule is 1 to 3 defibrillations for VFib. And if that doesn't work, I'm not going to try any further until their core temperature is above 30 degrees before I would try that again, because it's just not very effective. There's such myocardial. What these patients really need is warming measures before they're going to respond to any of our usual treatments. And then as far as medications, like we had talked about earlier, our body doesn't metabolize any medications at the same rate, and they're not going to work as effectively when we're hypothermic, just due to the drugs are designed to work at a certain temperature, pH, and it doesn't work well when the core temperature is less than 30. So she had received several rounds of epinephrine and amiodarone, and honestly, that if they had known the core temperature is less than 30, we wouldn't have done any of those medications. Once the temperature is greater than 30, you can go ahead and start those medications. But at that time, you want to double your interval of dosing when the temperature is between 30 and 35, because again, you're still just not metabolizing these medications at a normal rate. So our epinephrine, instead of every 3 to 5 minutes, we do every 6 to 10 at that stage. And then once the core temperature is 35 degrees, at that time, we can do normal intervals, normal dosing of medications in a cardiac arrest patient. So they had started CPR on this patient at about 1600. And when she arrived at the ER, they placed a temperature sensing Foley. And this was a shot of her initial vitals. So at 1629, 29 minutes roughly of CPR, they didn't have the exact time charted. And her core temperature was 21.4 degrees, or in American units, no, in Fahrenheit, it was 70.6. So that is certainly profound hypotension or hypothermia. And we all said, oh gosh, this is going to be a challenge. So we started some active internal rewarming measures on her. She had her chest tubes placed. They started thoracic lavage. One of the residents placed a central venous catheter, not the warming catheter. They didn't have that at our level 1 trauma center, but they placed that for resuscitation. They started warm fluids. They started the warmed humidified oxygen through her endotracheal tube. And we're kind of trying to figure out, what are we going to do? This person is so cold. So they said, all right. So they got some initial labs on her. Her pH was undetectably low at less than 6.7, which is the lowest our machine will read. Her potassium was surprisingly normal. Her glucose was undetectably high, which was a bit of a surprise to everybody, with a very low bicarbonate and a high anion gap. Her lactic acidosis, I believe, was normal. So they were like, oh my gosh, is this patient also in DKA in addition to being this hypothermic? And then her hemoglobin was 6.8. So they're like, does she have a GI bleed? Like, what is going on with this person's labs? And then anytime that the compressions were paused, that was her strip on the monitor. She was found to persistently be in ventricular fibrillation. So one of my colleagues called me. He told me this was coming and then called, and he said, Jenny, he's like, I know you always say that, we have to code these people until they're warm and dead, but this is futile care. Her core temperature is 21 degrees. There's no point in this. She's profoundly hypothermic. We don't know what's happened. Her pupils are fixed and dilated. She's acidotic. This is just going to take, hours to try to warm this patient, which is fair. And if you were in a low resource setting, these are things that you have to consider, that sometimes you would say, we don't have the resources to continue this, unfortunately, and, would have to stop. However, this is a level 1 trauma center at an academic institution. They have resources here. So I pushed back a bit, and I said that she looked very young. This is a 30-year-old. It was just an hour ago that somebody saw her moving around, moaning. We don't know how reliable that historian is. Was it an hour? Was it 2 hours? But recently, someone was adamant she had been making noises and moving and was still alive. And her potassium was normal. She had not been in cardiac arrest for a prolonged period of time before they got there. And she still was in ventricular fibrillation, which tells me her heart was still working in some degree. She wasn't just asystole. So I advocated that this is the perfect person for ECMO. And we called our cardiovascular surgeons at our neighbor hospital and made our case, which we have done several times in the past. And each time they've heard us out patiently and then said, no, thank you, not the right patient. We all agreed she probably has a poor prognosis, but this is the perfect candidate. She's young, she's in VFib, and her labs are normal aside from her hyperglycemia and acidosis. And surprisingly to us, our surgeons actually said, you know what? Yeah, this sounds like the perfect patient for ECMO. So we said, oh my gosh, let's go. And we continued to warm her, all the active internal measures that we were doing, and arrange for transport. And at 1 hour after she had arrived at our facility, because it took some time to get a hold of the surgeons and make our case for them to make some phone calls, confirm they had an ECMO circuit available. 1 hour after she arrived, our medics arrived to transport her to our sister hospital, which is about a mile away, with ongoing CPR and ongoing warming measures. And we did have to send some higher level staff with this patient due to the complexity of the case. We had to send a nurse and one of our resident physicians, I believe, with her. So they arrived and the ECMO team was ready, gowned up with all of their equipment, waiting in the ICU room when she arrived, and they cannulated her immediately for ECMO. At that time, one of our emergency medicine trained ICU, cardiovascular ICU attendings was there and was doing a bedside ultrasound. They found she was still, despite the fluids she'd received, I think 3 liters at this point, was still very volume depleted. And due to her low hemoglobin that was even lower on repeats, they started giving blood products as well as IV fluids and through a warmer. And they found that the initial, I don't pretend to be an expert on ECMO, but the initial flow on ECMO was very low, which also made them concerned that she was volume down. So they said they gave enough products that the flow improved to show that they had enough circulating now to make this a little more viable. And then they did opt to start her on amiodarone for her persistent ventricular fibrillation, which you can make an argument maybe wasn't the best call just due to her low core temperature. It's not going to be effective, and the risk of toxicity due to decreased metabolism. But at this stage, everyone was just trying to do anything they could to try to help this patient because she was still in ventricular fibrillation. So after 4 hours of CPR from when the initial call went out and now 2 hours on ECMO, they had got her core temperature up from 21 to 30, which is a very rapid warming for a patient like this. So that was a win on their part. So that's only about less than 3.5 hours of actually being warmed. At that time, she was still in VFib, and they defibrillated her 1 time, and she was then in sinus rhythm and had a pulse on her own, although they did continue ECMO for warming measures. So checking on her, her problem list was quite extensive. She was found to be in DKA and required an insulin drip. With all of these massive, the blood transfusions, the hypothermia, the acidosis, she did go into disseminated intravascular coagulopathy and required what we call massive transfusion protocol of platelets and blood, as she was bleeding significantly at this time. She was hypotensive. At this time, they had her core temperature above 30, so they did start her on 2 pressors. And she was noted to have a bloody bowel movement concerning for a GI bleed. They were concerned for ischemic bowel. She was started on IV pantoprazole at this time. She was still acidotic, so they had started her on a bicarbonate drip to try to counter the acidosis. And then due to the infusion of large fluids, blood, and volume, she now had diffuse pulmonary edema with a near whiteout on her x-ray and required pretty high ventilator settings to maintain her oxygenation. And then they also found on an echo on bedside ultrasound that she had a moderate-sized pericardial effusion, and they felt that she was at this time too unstable to go to get a pericardial drain or even a bedside pericardial centesis. They said she wasn't in tamponade, so they decided just to monitor at this time. So although we are now warm, you can see that these patients, even if warmed, can have a lot of other comorbid conditions that appear either that were part of the cause of why this patient became so hypothermic, or as a result of all of the interventions we had to do. So hospital day 2, she was actually doing a lot better. Her vitals were stabilizing. She had a decreased pressure requirement. Surprisingly, her labs were normalizing, and she was off of amiodarone. She was off of the bicarbonate. Her glucose had normalized. Her anion gap had closed. She was off the insulin bicarbonate drips, and her DIC was improving, and they were cautiously optimistic about her labs. Unfortunately, on hospital day 3, she had been stabilized enough to go and get a CT scan of her head at that time, as she was still not requiring sedation, that did show an anoxic brain injury. And she had an EEG that had fairly minimal activity with a poor neurologic prognosis. They did manage to identify the patient by fingerprinting, and they were trying to contact her family without a whole lot of success. And then since this time when I sent the slides, they did ultimately a few days later confirm brain death, and she was withdrawn from life support and did die. So this patient, it's kind of a bummer again. I sometimes hate to present these cases that don't have great outcomes, but that's the unfortunate reality of all of our jobs. The positive of this patient is this is the first hypothermic arrest in our city, in our region, that ECMO is utilized for warming and resuscitation, and objectively, quite successfully. They were able to get her core temperature up. Even her labs and all of the other comorbidities did normalize. And this is a person that, although she wasn't saved, we can use these lessons in this preparation to be more prepared for the next patient who may have a much better chance of recovery. This is someone that we look at and say, you know, if it weren't for the anoxic brain injury, this patient could have been salvageable. We presume she probably was, with this one, we're all presuming she probably was in DKA, and that led to her altered mental status and unable to get out of the cold, complicated by her homeless state, and was down and probably had been acidotic and hypoxic for a period of time before she became hypothermic. If that had not been the case, and this was more of a primary hypothermia, we anticipate this is someone that could have had a good outcome. So we're all a bit bummed. We are all very hopeful about this patient, but it was an opportunity for our teams to work together and hopefully have a plan for the next patient. So, you know, next time the next one might be salvageable. Questions on this one?
Колеги, хто має питання щодо цього кейсу? Maybe everything is clear in this for this.
Clear, except I am actually highly interested about your future. I suppose she's still alive, really, because so strange situation. Forest, young woman, female, and what happened? I suppose she's alive still.
Yeah, it was unfortunate. You know, we wish that she would have survived. This would have been a great case if she did. But either way, you know, we hope that in the future, the things that we learn from this case can help us for the next. And then Maria, I have one more case. It is up to you. Would you like me to proceed? I know we're kind of at the hour mark. I don't know what your schedule is.
If you have free time for us, we are ready.
Okay,
I know
sure.
that it's not so long case, so maybe
Yes.
10 minutes.
Yeah. Yes, and it has a good outcome. So, all right.
Yeah, thank you.
So the last case we'll talk about is a 46-year-old gentleman. Again, we're seeing a theme here. This gentleman was found on the sidewalk by EMS, and he arrived with a chief complaint of hypoglycemia. Our paramedics were unable to get an IV prior to arrival, but they were close by, so they just went ahead and brought him here. Our glucose read low, and the patient was pretty much unresponsive upon arrival. So we placed an IV on this patient, and we gave him an amp of dextrose, and we waited and waited. We looked at him, and his mental status improved a little bit. He was moving around. He wasn't unresponsive any longer, and our repeat glucose was on the high side of normal at this time. But he wasn't following commands. He was still agitated. Although he was moving around, we didn't know any history on him. He arrived as what we call a John Doe, but we weren't sure what was going on. However, at this stage of the lecture, everyone here says, yeah, but this is a lecture on hypothermia. So you are correct. We got our initial vitals, and we found this patient to be hypothermic with a core temperature of 26.1, so kind of in the initial range of Granny and our individual that went into VFib, a little warmer than our young lady on the last case. We found that his vitals were a blood pressure of 100/50, a heart rate of 84, respirations were normal, and his oxygen saturations were pretty close to normal. We put him on some supplemental oxygen. And this is one that I looked at and I said, and turned to my resident and asked, is any of this surprising? Yeah, and to me it really was. I mean, his vitals look pretty good. I have plenty of patients in the emergency department whose vitals look way worse than this on a daily basis, whose core temperature is much higher. This is a profound hypothermic patient that by the stages of hypothermia, he should be unconscious, unresponsive, with pretty poor vitals, and he really looked pretty good. But he was agitated, and so we figured that was probably influencing things a bit. While it's surprising to have someone with a core temperature of 26 that's agitated and moving around, it can happen. These people aren't always completely obtunded. But our concern with him being agitated and trying to move around on the stretcher, like we talked about, was what if he sends himself into a dysrhythmia? Us jostling him or him jostling himself, either way could go into VFib, and he certainly is in that hypothermic range that we worry about that. But then our conundrum was, but if we sedate him, is this going to make his blood pressure and heart rate drop? And is that going to send him into cardiac arrest? So how do we balance this need to sedate him to facilitate not going into VFib with the hypothermia and the differences in drug metabolisms? So we looked, and there's really no guidelines for sedation in these people, because by the textbook that this gentleman didn't read, he was supposed to be unresponsive at this cold of a temperature. But we figured, okay, probably the metabolism is slowed due to his core body temperature. So we decided to give a smaller dose. We gave him 1 milligram of Versed midazolam IV, and we said we'll do just 1 milligram intervals to see what happens as we try to rewarm him, just to keep him calm. And then for this person, we're going to talk about, what methods we use for rewarming. We've talked about passive, active external, active internal, and then the more aggressive active internal measures. So for him, we'd want to do active external measures. Again, if he went into cardiac arrest, we would then consider the more invasive active internal. So for him, you're seeing a theme here. We started warmed fluids, warmed humidified oxygen, and then we placed a bear hugger, the forced warm air device, on him, as well as some warm blankets around his head and in the around the big blood vessels in the groin, the axilla. Again, sparing his extremities best we could to try to avoid that after drop. So now we gave him 1 of midazolam, and he's now resting quietly and calmly. His blood pressure did decrease a bit, as well as his heart rate. But with these, we figured these are probably more accurate initial vitals, more in line with what we would expect. Actually still pretty good, but we feel that initial set was influenced by his agitation. But we would rather have him with a slightly lower blood pressure and heart rate and a lesser risk of going into ventricular fibrillation now that he's not agitated. So we said, okay, and we kept warming him. We got our initial labs, and they were largely unremarkable. The initial blood work we had drawn with IV placement showed hypoglycemia, but we knew we had corrected that at this time. His CK was mildly elevated, but everything else looked pretty good. His chest x-ray, which was a portable, we didn't want to jostle him, but it was a portable, it was normal. EKG was normal. The residents wanted to get a CT head, and I told them they were not allowed until he was warmer. They agreed, finally. That looked good. So he actually rewarmed very rapidly. Within an hour, we already had his temperature up out of that profound hypothermia stage, or right on the border, to 28.3. And now the patient was able to tell us his first name. He was a little bit agitated. We put him in soft restraints, but he was a little more able to redirect at this time than he had been. And again, our blood pressure and heart rate are now improving. So we were feeling pretty good about this case. We'd left the resuscitation room and said, okay, we'll just keep warming him. He's out of the danger zone. And then 20 minutes later, our nurses called us back in and said, it's not that easy. He's now completely obtunded. He's not responding to anything. And our blood pressure and heart rate are dropping, but our temperature is still rising. We're like, well, what's going on? What happened? We were fixing him. He's warmer. His vitals looked better. Well, don't forget that your basics on these patients. You still have to remember everything else and the other problems we're managing. We got a repeat glucose and found it again to be critically low. So we gave him another amp of dextrose, and almost immediately his mental status, his heart rate, and his blood pressure all improved. And he had a couple episodes of this where his glucose would drop, and we ultimately placed him on some dextrose-containing IV fluids. And so this patient, as we continued to warm him, he'd received 3 liters of IV fluids. These people are usually pretty profoundly dehydrated from a cold diuresis due to the vasoconstriction and the shunting of blood to the core makes the kidneys perceive that they're fluid overloaded, so they diurese. So once you start warming them, they're very volume down. So he received 3 liters of fluids and was still hypotensive at that time. We were concerned, is there something else, some infection or something going on? So we did go ahead and start him on a low dose of norepinephrine once his core temperature was over 30 degrees. And at that time, that actually worked well and kept his blood pressures in a more normal range. And then once he got a core temperature up to 32 degrees, we were comfortable with him being moved a bit. And we talked to our ICU doctors and got him admitted. They insisted on a CT scan of his head, although his mental status improved, which was also normal. So we now had found out who this patient was, and we were able to review his old records and found that he had a history of poorly treated schizophrenia and was we have a term called frequent flyer. He was a known individual to our psychiatric services and in the hospital. Over the next 24 hours, his mental status did improve. He was awake, he was following commands. He knew his name, but he didn't know time or situation. But we found that to be likely his baseline with his underlying schizophrenia. And then after he was able to warm up to the point that he was maintaining well enough to eat a normal diet, his hypoglycemic episodes resolved and he was able to come off the dextrose-containing fluids. So the patient ultimately got transferred out of the ICU to a regular floor bed. He did have some intermittent episodes of agitation and was kind of a complex care case in that sense that he would refuse his psychiatric medications or refuse medications and was somewhat altered and agitated, but sometimes not so much to the point he could be treated against his will. So psychiatry was very familiar with this patient and they consulted as an inpatient and stated that unfortunately it was pretty much his baseline and they knew him well and that they did deem him to have decisional capacities at that time. So unfortunately, on hospital day 4, he did decide to leave against medical advice while they were still trying to stabilize him. They had hoped to be able to convince him to go for further treatment for a psychiatric disease, but he was unwilling to do so. However, on a positive note for some follow-up, this patient has now been seen an average of 2 to 3 times daily in our psychiatric side of our ER since that time. So he's getting some good follow-up. We see him frequently. He is unfortunately homeless and remains with poorly treated mental health conditions, but has had a good outcome with no neurologic deficits despite his core temperature and all of that. So always good to see them out and about and doing with a better outcome, but unfortunate that he is a failure of, unfortunately, our medical care in this country. So kind of a summary of some of these patients, the core things we've talked about again from both the previous lecture and here, just the points I want to hit home one more time before we conclude. As we've talked about, these patients are very fragile, and you want to make sure that any jostling or position changes are done as minimal as possible and to really try to avoid those ventricular arrhythmias on them. And then these people, because they are such a resource-intensive population that take a lot of time, personnel, unfortunately, money and resources to warm, you want to try to get them to a higher level care facility if possible. These are people that are best served at hospitals with more capabilities if that is an option. And the goal is to rewarm them as rapidly as possible by whatever most appropriate means there are. There is not a too fast when it comes to warming. It is as fast as you can get their temperature up. But keeping that in mind, especially if you're using more active external measures, you want to avoid warming the peripheries and focus on the core, trying to avoid that afterdrop phenomenon that will cause their blood pressure, their heart rate, and their core temperature to dip once you start those initial warming stages. And then again, there's a limited use for defibrillation or medications in these patients if their core temperature is less than 30. 1 to 3 defibrillations for a core temperature less than 30 if indicated. Otherwise, just keep warming until they get to 30 degrees. With those people, there's really no indication for repeated pulse checks, more medications, or more defibrillations until you get them warm. And again, we always say these patients are not dead until they're warm and dead. So, all right. Any questions for me? And I've posted my email there if anyone has any further questions. And then shameless, one of my pictures from Antarctica from my last trip.
Hello, I have one question. Can I So maybe I missed it, but is it typical that high glucose is correlated with hypothermia?
It is not. That was a surprise to us as well. We never found out that lady's past medical history, but we suspect she might have had underlying diabetes, and DKA might have been the actual precipitating event. She might have went into diabetic ketoacidosis, had became altered, and then was unable to remove herself from the cold environment, leading to her hypothermia. So we suspect that might have been what actually triggered all of that. Hypoglycemia can be somewhat more common, just as these patients have kind of depleted all of their caloric reserves, like our last individual who had been out in the cold and not eaten. So I've seen hypoglycemia a few times, but the hyperglycemia with DKA was a good reminder for us to keep the differential broad and remember that something like that, a metabolic process, could have been the thing that actually led to her being in a situation in which she became hypothermic. So.
Okay, thank you.
Colleagues, guys, maybe more questions?
Yes, please. Madam, I would like to find out how hypothermia typically differs from the use of ice to assist or to support cardioplegia in cardiovascular surgeries, because typically you're using ice, you're moving the heart. Why are we not having concern for the VFib, as you mentioned with the case of moving people that are suffering from hypothermia?
So my understanding is there is certainly a concern for inducing, like if they're doing an open heart surgery or a heart transplant, something like that, and they're packing ice around the heart, that is very common for them to go into ventricular fibrillation or ventricular tachycardia. My understanding is the goal with when they try to cool the heart for those surgeries is they cool it very rapidly to the point of usually asystole. And I believe they have some medications they can use to try to help induce that, but I'm not a cardiothoracic surgeon. But my understanding is usually like in a transplant, when they start rewarming the heart, when the patient's coming off the bypass circuit and they're, finishing up surgeries or all those things and warming, it's very common the heart usually is in ventricular fibrillation or ventricular tachycardia that does require a cardioversion or defibrillation to try to get them back into sinus rhythm. And I know those patients post-operatively are very high risk for arrhythmias and are all like prophylactically on amiodarone. And that is like a very, very common thing. So even in instances where hypothermia is intentionally induced, the risk is the same with the VFib and VTAC.
Thank you.
Thank you, Jenny. I think it's